Hello, I'm Dr. Omar Bay, and this is OBHealthy Physicians Health Network. And welcome, everyone. So glad that you can come and listen to us today because it's all about health and wellness. We're a group of Black physicians that have two main focuses. And the number one is to improve for people of African descent. And that's so important because if you look at the statistics, we seem to be on the top of all medical statistics, and we need to improve that. The second is to encourage young Black men, oh, young men, I should say, to go into medicine because we need you, and it's a profession where we feel that it's so necessary for African Americans or people of African descent to see someone that looks like them when you're being treated. So we are encouraging young Black men to go into medicine. That's our focus. Our webinar is every second Saturday at 1 o'clock. And what you do is all you need to do is let me click this off. All you need to do is go to OB Healthy and hit the physicians tab at the top on your border, and that'll bring you into a page that you can come in and be a part of our webinar. And at that point, you can type in your medical questions. And please do not be shy. Give us your medical questions because we're here to answer them. We really are. We expect those questions to come in. All righty. If you want to see our past webinars, please, all you have to do is go to OB Healthy and hit the YouTube logo. That YouTube logo will take you to all our past webinars, and please check them out. Alrighty. I would like to thank OB Healthy, and I've mentioned it several times, for allowing us to bring this to you because they are our sponsor. Alrighty. Uh, Look at that. Please do not, and this is the most important thing that I can say, please do not change any aspect of your medical care, no matter what we say, because only your doctor can truly take care of you from a true medical standpoint. Hold
Omar, I
on just
think
for a second
Dr.
here. Thank
Curtis
you.
has got some background noise.
Get clean, healthy water in your home today.
Shouldn't.
Let me get that muted. Thank you. Thank you. All righty. So we are so excited. Well, I'm so excited because we have two excellent physicians. I mean, we're really going to show out today. We have two excellent physicians, and our topic is women's health. And it's so appropriate because of things that are going on, and you see it in the news and all of this stuff about women's health and how we can improve it. Let's see YouTube again. All right. So what I'd like to do is introduce them. And first, I'm going to go in order. I want to introduce Dr. Damali Campbell. And let me read her bio. Both of them sent me a bio, and I'm just like awed, tell you the truth, and be very honest with you. So we will get this together. Um, Dr. Damali and Dr. Molly Campbell, I should say, she's board certified obstetrics and gynecology and addiction medicine. Her special interest is within women's health and it includes broadening health education and literacy. She has spearheaded several programs focusing on community health, including implementing centering pregnancy and improving pregnancy nutrition. And that's my love there, nutrition. So I'm happy about that. Dr. Campbell also sees and manages women who are pregnant. Dr. Campbell also sees and manages women who are pregnant with tobacco, alcohol, and opioid use disorders, and manage both the pregnancy and the medical aspect of the addiction. And that's important. She is a faculty member on the Student Affairs Committee, interviews for admission committee, and faculty advisor and mentor for student groups at New Jersey Medical, and at the New Jersey Medical School, right, Dr. Damali? Dr. Campbell also is president of New Jersey Medical Association. This is the New Jersey state chapter of the National Medical Association, the country's oldest organization representing physicians of color and the patients they serve. Since 2022, she has served as the trustee for the executive board of the AMA, and that's the National Medical Association. So, boy, she's got a powerful resume going here. A member of the New Jersey Black Women's Physicians Association, and recently, Dr. Campbell has become the Secretary Treasurer of the New Jersey section of the American College of Obstetrics and Gynecology. You are bad. I'm glad to have you. Welcome, welcome, welcome. All righty. And let's get with Dr. Natalie Roach now. Now, Natalie, ooh, I'm impressed here too. You know, y'all doing it. Dr. Roach, um, she received her bachelor's and at Barnard, okay, and then college and Doctor of Medicine degree at Mount Sinai Medical School. No, I'm impressed. I'm impressed. That's in New York. Her residency in obstetrics at Beth Israel Medical Center in New York as well. Dr. Roach began her career as a clinical instructor of obstetrics and gynecology. Guess where? At Yale. Go ahead, girl. I love it. I'm just going to cut this short because you have so many, and throughout the years, she's been at several prestigious places. In 2020, Dr. Roach became the attending physician at University Hospital. All righty. Department of Obstetrics and Gynecology in Newark and assistant professor of obstetrics and gynecology at that's University of Medicine and Dentistry of New Jersey Medical School. She is currently director of gynecologic services and chairperson. Let me get it right here. Okay. Oh, am I missing something? Hold on, hold on. I'm sorry, Natalie. Chairperson, I am missing, I'm sorry, I'm missing one of your
Okay.
things.
The chairperson of Credentials Committee for years. I just stepped down and became vice chair.
All righty, all right. Well, you please excuse me because I thought I had them all, but I think I missed a page. I'm sorry about that.
That's okay.
Missed a page. All right, here we are. Yes, yes, yes. Let's continue. All righty. Dr. Roach is presently an associate professor in the Department of Obstetrics and Gynecology and Women's Health at the Rutgers, New Jersey Medical School. She is also the director of the, is that generalist division in the Department of Obstetrics and Gynecology. And Dr. Roach is board certified in addiction medicine as well. All right. All righty. There we are. Both of you, you are here, and I am so proud and thankful that you could take the time and come and be with us. All righty. This topic is something that we've been wanting to get to for some time, and I just want to start off with, and you had given me several topics to talk about, and I'd like to start off with cervical cancer. It's something that African American females should know more about, I feel, and it's so appropriate to hear about this from a female Black physician. So, Dr. Campbell, can you start us off with just some general information about cervical cancer, some of the things that our females in our communities are you know coming in contact with? Just give us a start off here.
Sure, absolutely. First of all, thank you so much for having us. And especially this month in January, just to say that on January 23rd will be Maternal Health Awareness Day. And so I know we'll get to some topics about maternal health awareness. But cervical cancer is one of the gynecologic cancers that we screen for when women come to the gynecology office. It's really important that women be screened. And we've started to notice that there has been a decrease in the screening rates in the United States. And that's not a good thing because one of the things about screening that we know, and when we say screening in cervical cancer, we're talking about that PAP test. pap smear, people know it as, is that when we're able to screen people, this leads to fewer deaths because we're able to catch abnormal cells and precancerous cells very early. So let's start off at the beginning. All people who have a cervix should have cervical cancer screening, should have the pap test by the age of 21. And so where we go from there kind of depends on your background and your history. I think one of the things that has contributed to the decrease that we've seen in people getting their screening test is because our tests have gotten better. And it used to be that women would come to the office every year for their GYN annual exam and have the pap smear test. And we linked that GYN exam and that pap smear test together. Technology has changed over time. We have better testing. We also have what's called the HPV test. And so through many different studies, you know, the screening guidelines have changed, and we've said to women, maybe everybody doesn't need to have the pap smear every year. Some people can go 3 years, some people can go 5 years. And I think that's led to some confusion. And so, you know, we've seen this borne out in statistics that the screening rates have gone down.
Damali, could you tell us a little bit about what the cervix is? And you mentioned HPV, what HPV is?
Absolutely. So the cervix is the lower part of the uterus, what we call the mouth of the uterus. It's the part of the uterus that we see when we do a vaginal exam. We see it and we feel it. And so that's what the cervix is. Sometimes I compare it to, it kind of looks like a donut. And when we do the pap test, when we visualize the cervix, it's important for women to know just because we have put a speculum inside the vagina and look, that's not a pap test. The pap test is when we actually physically collect cells. You can use instruments, something called a spatula or a cyto brush, where we actually collect the cells. When I started training 20 years ago, we used to put it on a slide. Now we put it in a small vial container with some liquid, and we send that to the lab. HPV is human papillomavirus. And we now know that most cervical cancer is associated with human papillomavirus. And so most physicians, most clinics, most places where you go and have your cervical cancer screening, we typically do these things in concert. You get the cervical cancer screening along with the HPV test. And so we know that there are several high-risk types of cervical cancer, HPV, that are associated with cervical cancer. We also have a vaccine for HPV, which we want to talk about. And I see Dr. Patrick
Correct.
Anderson has joined us, and, you know, this is his specialty to treat. And once I make the diagnosis of someone with cervical cancer, I send the person on to somebody like him. And I see Dr. Court has his hand up, so I don't know.
I have one question. In reference to, you said that, may I? You said that patients should start at age 21. Does it matter whether they're active or not, sexually active?
And the answer is no. Whether you're sexually active or not, you get
Right.
screened for the pap smear. And people get confused because the HPV related cancers are really related to sexuality, that you've been sexually active. However, there are other cancers of the cervix that do not require any sexual exposure, and therefore everyone at 21 should start having pap smear, regardless of the sexual, whether they ever had sex or not.
Thank you.
But
Thank
you know, you talked about the vaccine, Damali. Do you think that there's a link between individuals that might have gotten the vaccine and a belief that maybe they don't need to have pap smears?
Absolutely not. So people who have gotten a vaccine still should undergo cervical cancer screening appropriate, starting at age 21. And then we usually would recommend every 3 years, and as long as it's normal until age 30. And if they are able to have this pap smear test as well as HPV test, then we can stretch that out to every 5 years.
Right. Patrick, you have a question? You're still muted, Patrick. You're still muted, Patrick.
I'm sorry. I was saying, Dr. Roche, Dr. Campbell, welcome. It's been a while, and this is probably in our field one of the more controversial political topic, especially at a time when we've gone through COVID, and the idea of vaccination and the worth of vaccines becomes questionable. But Dr. Roche mentioned that not all cervical cancer is HPV related, and it may be the minority, but when you see 2 cases in a week, that's non-HPV related cervical cancer, then one has to realize to our parents where this messaging needs to go, that the vaccination does not change parental counseling. It doesn't make a youngster, male or female, become more sexually promiscuous, which is oftentimes the conversation that happens. Well, but at the end of the day, when your child goes off to college, they get their dorms paid for, they get a computer, they get a pack of condoms, and they get vaccinated.
I'm a pediatrician, and the issue of HPV in the vaccine is, can be passed sexually between male and female. And initially, when the vaccine came out, it was just recommended for females, but then it became equally recommended for the males, because that is part of the way that it gets transmitted. And there are also some cancers associated with males. But as kids start to become sexually active earlier, maybe, than when I was growing up, this issue of having maybe cervical issues might possibly cause the need to have pap smears done earlier if one is more sexually active earlier. And so I know that these guidelines come up sometimes related to whether or not the insurance pays. But if you have someone who's been sexually active, at the age of 12 or 13, because the age of sexual maturity in terms of Tanner staging is such that most of the females are going to be having periods by the time that they're 13, and they may become sexually active around that time as well. So is there any thoughts about maybe having pap smears earlier in individuals that are sexually active earlier, rather than waiting until they're 21?
I'll answer that question. And the answer is actually no, because most of the young people are going to clear the HPV virus out of their bodies, and the data is pretty good. And Dr. Anderson will back me up on this, that it's really uncommon to see any cervical cancer under the age of 21. So looking at the data overall, the only group that's an exception to that is those who are HIV infected, and they are exempt. So that whole group of the immunosuppressed, we do start screening as soon as they make their sexual debut. And we do not follow those standard guidelines for those who are not immunosuppressed.
But Natalie, just a question about that as well, because I know that with HPV, we talk about its relationship to cervical cancer, but the same virus has been responsible for throat cancers in females, and it's occurring in individuals that are in their 50s and 60s. So even though they might have had HPV earlier and cleared it, it still may be responsible for causing some cellular changes later in life. And I'm not so sure about the cervix, but certainly there is a relationship between the HPV and throat cancers. And so we're not quite sure what the virus actually does to cause the cellular changes that cause it to turn into a cancer. So I was just curious about that issue, even though the cancers may come later, that it still may be related to earlier infections in life.
Well-
Sure, early infections, repeated infections that you get over time as you change sex partners. And it's not only the cervix, it's the throat and the anus too. All right. So we're trying to protect people from multiple sources. And before, men used to say, well, why should I be vaccinated just to help her? Well, it's to help you, it's to protect your throat. And depending on what your sexual behavior is, the male's anus too. So it's really important that we remember 9 through 45, we're supposed to vaccinate males and females. And then the other thing is that we all forget about venereal warts, and it's easy to forget about them because vaccination has made them disappear out of our practices. I do colposcopy, which takes care of abnormal pap smears. Half of my work used to be warts in the vagina and the vulva, and use of HPV vaccine has really decreased that markedly.
Excellent, excellent. We have a couple questions. Can we let's take one. How often should a female over the age of 65 have a pap smear?
Well, I'm doing a lot of talking, so I'll let Dominique take this one.
Yeah. So again, a lot of this goes back to the history of the pap smears. And if a person has had normal pap smears, then it's generally accepted that they can stop having cervical cancer screening at the age of 65. You know, we've been talking a lot about controversies. And I think one of the things that we need to think about is, you know, the questions that we ask and really getting the history from our patients, because while we might say it's okay to stop cervical cancer at screening at 65, maybe for a patient who has the same sexual partner with no change, sometimes people may have a change of sexual partner, and that could even occur in someone who's in 50, 55, 60. They may have a new sexual partner. And so if there is a change in sexual partner, it may be appropriate. And the same thing, I think, when we think about our younger patients, we have these guidelines are guidelines, and they really are geared towards patients that have had several normal pap smears and have not had a change in their sexual partner. But we need to be careful and make sure that we're getting, you know, a good, thorough history, because we may need, the guidelines are just that. They cannot predict every single situation for every individual patient. And so I like what you said, Dr. Bay, don't change anything you're doing without talking to your individual physician who you confide in about your history.
Right. And I'm going to be very strong about this particular issue about 65 and older, since I'm over 65 myself.
Stop bragging.
You have to have 20 years of normal pap smears by the time you hit 65 before you can stop
Correct.
screening. And yes, what the woman is doing in terms of her monogamy is of interest. But then the question is, what is he doing? So what you have to do is bet your cervix and your infection rate on what your sex partner may be doing. All right. So the woman has to make a decision herself. If she's got 20 years of normal sex partner, she looks over at Fred and says, I'm not sure what Fred is doing. Continue doing your pap smear. All right.
And again, it goes without saying that you have to have a cervix in order to have a pap smear, right? If you've had a hysterectomy, you would need to do that, right?
So generally speaking, no, but if you've had cervical cancer, then we still do a pap smear of what we call the vaginal cuff. So again, that each situation is really individual, and it's really important for women to have that conversation. Just yesterday, a couple days ago, you know, in fact, my medical assistant was trying to convince the patient that she didn't even need the pap smear. But in terms of my consultation, what I found out is the patient had a hysterectomy, but she had a hysterectomy for carcinoma in situ. So I said, no, it's absolutely imperative that she has a pap smear. So it all lies in the history.
Still no picture.
All right. Dr. Anderson, you have your hand up and you've been so patient.
Yeah, it's refreshing to. I know Dr. Roche and Dr. Campbell for a very, very long time. And when we're in this business, sometimes most of what we do is based on our opinion. And what these colleagues of mine are doing is really citing evidence-based medicine. And HPV related research and cervical cancer research, if you ever want to study epidemiology, it's a good example of how to develop these studies for the simple fact that you have a causative agent which is identified. There's multiple serotypes which behave differently, but the behavior can be monitored. You have a vaccine against it. And when it comes to cellular changes, not only you don't go from 0 to 100, you have a pre-invasive condition which can be first evaluated and treated without it become invasive, and then treated in a manner that's not invasive. So the whole cervical cancer and HPV database does is clearly shows that patients who develop cervical cancer are the patients where the infection is recurrent or it persists. Because most women, even with the high risk HPV, do clear the virus, usually within 24 months. So it's after 24 months, if we're still having conversations regarding persistent infection, that's the patient who gets put in a different risk category, right? And then, it's not one size fit all. And life you know, is not just going down the same avenue. People's habits change, partners change, lifestyle changes. So with respect to recommendations, like Dr. Campbell mentioned, the whole issue of 65 to 70 has everything to do with, as Dr. Rose says, what happened the previous 20 years and whether the consistency remains. If your circumstance changes, then your risk category changes.
So what happens if one is diagnosed with cervical cancer? What happens in terms of treatment and follow-up?
Well, I want to interject one thing before we go back to Dr. Anderson and answer that question. And that is, once the abnormal pap smear does happen, Black and Hispanic women tend not to return for their follow-up visit to follow up the abnormal pap smear. So the data it just came out in GYN oncology report that 1/4 of the patients who are Black and Hispanic with these abnormal pap smears never return. So before we get to the cancer treatment, we're trying to prevent cancer, and we want the patients with an abnormal pap smear to not fear, to please return to us so that we can go ahead, make a diagnosis, and help prevent them from getting cervical cancer. Now, Dr.
And I would like to say one more thing as well, and that is, the women that we're looking for, primarily, we talked about the fact that screening is going down, but the women we're looking for primarily are those who have not had a pap smear in the past 3 to 5 years. So every year we have a free cancer screening program for people who are uninsured and underinsured. And, occasionally we see patients who come year after year, but we're really looking for patients who have not had that pap smear in the past 3 to 5 years, because oftentimes we do in the emergency room also sometimes see patients who come in with bleeding, and we do an exam, and now we see, this fungating cervical mass, and we have to do a biopsy, and then they get a diagnosis of cervical cancer. And then I have to refer them to my colleague, either at my institution or someone like Dr. Anderson, who I've referred to on many of occasions. So once we have the diagnosis of cervical cancer, then we send to Dr. Anderson, and he, I'm sure, is going to walk us through what the treatment looks like.
To Dr. Roche and Campbell's point is, the number of patients who do not return is unacceptable. Because here's a piece of data that the incidence of operable cervical cancer has actually gone down. So we're actually seeing more advanced disease than we're seeing operable disease. Not to say that that's a bad thing. It's bad from the standpoint of the patients with that advanced disease are those patients who did not return. The reason we're not seeing operable cases is because the screening is good, the vaccination is effective, and the treatment of the pre-invasive lesions are effective. Now that said, you know, when you get diagnosed, and I have to say, about 15% of all our new cases we see in the emergency room, right? And that in of itself speaks to inadequate follow-up. Once we confirm the diagnosis, then you start to think about staging. And what staging means is how far it's spread. And there are factors in the cancer that tells you who may do well and who won't. At face value, you know, we talk about the grade, meaning how it looks. You know, a 1 versus a 3. 1 has a better outcome than a 3. So, you know, a stage 1 grade 3 cancer may be worse than a grade 1 stage 2 cancer. And then there are other, what I call intrinsic biologic factors that does influence each individual's cancer. And that has to do with the actual genetic change that has occurred within the cells while they undergo transformation. Now, you know, fortunately, we really have effective treatments in terms of treatment availability that is quite effective, even in advanced disease. You know, once Dr. Roach sends me a patient, then what I do is confirm that her biopsy is what they say it is. She's not the one reading the pathology slides, someone else is. So what she does is say to the pathologist, this is what I see, this is what my concern is, do your best job. And once I get that, I actually get the slides and review them, because there are factors that influence the treatment management. And the first step is to really do a good exam on the patient. One of the conundrum in gynecology is some cancers are surgically staged, and what that means is you have to operate on the patient, take lymph nodes and biopsies from several locations to say, well, this is how wide it's spread. Fortunately, for cervical cancer, it grows locally first before it metastasizes. So that lends it to become clinically staged, right? So when Dr. Campbell sends me a patient, she actually have a good idea as to what stage it might be, just based on her exam. And the treatment is specific to stage and to age. Most patients who are younger at an early stage, oftentimes fertility is an issue. So you have to think of fertility sparing approaches to some of those patients. And that can be a conversation for a whole day. But it comes down to, do you operate on someone who's young, who has never had a child, or who has had children and want to have more children? Or do you do something where, you know, you can remove the cancer but spare the rest of the genital tract, including the uterus and the ovaries? Or do you do something like egg retrieval, store those eggs for a later date, and do what you need to, and then she can reproduce via a surrogate? But there are two main approaches to treating cervical cancer. One is surgery. The other one is radiation plus or minus chemotherapy. Surgery is usually appropriate for younger patients, but also in the early stage. So a stage 1 is where the disease is confined to the cervix. But even within that stage, there are subgroups where surgery is not appropriate. And it has to do with the size of the lesion. So if you do a biopsy on a cervix that looks normal to the naked eye, and it comes back invasive disease, then that's probably an early enough stage where surgery will be helpful. If it extends onto the vagina, but it's just on the surface and it's close to the mouth of the womb, maybe that's someone where a radical operation will be helpful. But if it's beyond any of these points, then it becomes primarily radiation and chemotherapy. Now, in some cases, you can do radiation for a short while and then do surgery. The advantage of doing that is you can preserve some tissue integrity, right? Because as you know, radiation has a short-term effect and a long-term effect. And the long-term effect usually has to do with tissue being compromised, and it has everything to do with the microvasculature. So, to the naked eye, the tissue becomes somewhat rigid, inflexible, the nerve sensation changes. So you have to struggle with some physiologic function with radiation long term. However, at all stages, in all early stage, both surgery and radiation plus or minus chemotherapy has the same long-term outcome in terms of survival. Now, that's important because not everyone, young or old, is a good surgical candidate. So those patients who are not able to have surgery need not be dismayed. There is still good treatment approaches that could eradicate the disease. Now, for advanced disease, the combination of surgery plus chemotherapy, usually a chemotherapy regimen that includes a platinum, which is a specific group of chemotherapy drugs, is quite effective. And the data is old, it's mature, and it's proven over time to be very effective. And then for patients who's failed those upfront therapies, fortunately, we have newer targeted agents, which we can talk about ad nauseum. Some of it immunotherapy, some of it, some other targeted agents that targets vessel formation that in combination with other therapeutic agents is very effective. And then I'm a strong proponent of patients who fails all of that to enroll in a clinical trial.
Excellent, excellent, Patrick. Dr. Sprock, you have your hand up.
Yeah, I didn't want to let Natalie off the hook after she raised this, I think, critical issue. I mean, we talked about the issue of trying to identify things early. And if you have a pap smear and it's abnormal, there are people that don't follow up on that. And I think there's possibly an implication of fault related to the patient that doesn't follow up. When, Damali talked about literacy, and people that don't maybe quite understand the ramifications of abnormal pap smear and the need to follow up, there might be barriers that need to be examined to try and close the gap to get them back in. Have you tried to identify or studies been done to look at why women who have abnormal pap smears don't follow up?
Actually, we have a lot, as I mentioned, the cervical cancer screening program that we run at the hospital once a year, really geared towards uninsured and underinsured patients. A lot of it is the social determinants of health barriers, access to care, whether people have insurance, and the time that they take off to go to work, to have an appointment. Many of us, we have employment, we have paid time off. There are folks in our community, if they don't go to work, they don't get paid. If they don't get paid, they can't make the ends meet. There's childcare barriers, there's transportation barriers. So there are lots of barriers for people. And I think, again, to your point of health literacy, one of the things, a lot of times if I ask people, when's the last time you had a pap smear? They say, well, I had it in the emergency room. Most physicians know we don't do pap smears in the emergency room. So it's really important for us to understand, for clinicians, when they're doing an exam, to say, I'm doing a pelvic exam, but this doesn't replace, you still need to go to the gynecologist and have your pap smear. So we need to make sure people understand what kind of exam that they're having done, so that, we can overcome some of these barriers.
And then the
I hate
other
to
thing
raise
is,
it, but one of the questions I have, the demographics within this country have changed dramatically over time. And I follow demographics, and if you look at children, under the age of 21, 35% of the children, the individuals under 31 are Latino, 15% are African American. So you're talking about maybe over half the population of that are having kids are Latino and African Americans. And it always makes me wonder if that patient population in general isn't necessarily getting the kind of follow-up that they need. And again, there are differences that have been pointed out between whether or not Latinos are taken care of by Latino physicians or African Americans taken care of by African American physicians. But the changing demographics of who's graduating from medical schools has changed. When I was in medical school, we had 10% of our entering students were Black. The numbers of African Americans entering medical school, especially males, has declined. I'm not sure that the number of Latino graduates of medical school has increased. And so you have this disparity in terms of the healthcare providers who look like and talk like the patients that are coming up. And I just don't know whether or not that's a factor or not. I know, given where you are practice in Newark is a little bit different, but you go to the public schools and you see the Latino populations of the schools is very high. And there are issues of immigrants and there's a lot of political issues there. But I am concerned about whether or not that's a factor in the number of individuals that are not following up because they may not understand, or their language barriers or things like that.
Well, I would like to say it's even more fundamental than that. Did you even get the abnormal results? All right. And a problem is that with a population that, if you're poor, you tend to have a high mobility, meaning you move from place to place. So if you don't have that kind of healthcare literacy where you can use MyChart or some of these other mobile apps where you can actually see your own lab results, if you're relying on somebody to call you, reach you, find you to give you that abnormal Pap smear result, and you've moved 2 times since you had it, it really can be very, very difficult. Or your phone is, you don't have minutes on your phone, or whatever. All right. So I think that the system itself is a failure. We already know that every one of us has a swipe card for all of our monetary issues. You go to the bank and all your data is on that little swipe card. They can do the same thing with a healthcare card, so that no matter where you go, people can swipe the card and see your data and see all your results. We just have not put the effort in a very mobile society, because it's not just poor people who are mobile. Everybody's mobile. Everybody changes physicians frequently because it's in terms of what job you have, what insurance cover you have, therefore what network you're in. So I think the whole system is not doing everybody or anybody a real service in terms of, we're talking about Pap smears, but I'm talking about just getting results and doing follow-up in general.
Excellent, excellent. Let's tackle another question. And this one says, after having a hysterectomy, is it common to have breast cancer? I don't know how you relate the two, or if they are related. I'm sure that in some way they can be. If you can give us some explanation with that, or if anyone has any experience with it.
I don't know if Dr. Anderson wants to go in, but I would say I don't think it's any more common to have breast cancer after having a hysterectomy. But again, I think it goes back to our conversation about health literacy. A lot of times it's very important for women to understand, if they had a hysterectomy, what kind of hysterectomy did they have? Was their cervix removed when they had a hysterectomy? A lot of times people have hysterectomies for bleeding or fibroids. It's important to know whether your cervix was removed, because if you had what we call a supracervical hysterectomy, if your cervix was left in, then you do still actually need to have a Pap smear and have your regular Pap smear screening. Sometimes when a hysterectomy is done, the ovaries may be taken out or may be left behind. But really, if the ovaries are normal and the hysterectomy is being done for a benign reason, the general recommendations are to leave the ovaries in place, because they are what produces your hormones. So I don't believe that there's any increased risk of breast cancer after you've had a hysterectomy.
All right. We
Could you
got
tell us
quite
what
a
a
few.
fibroid is? You raise fibroids. I don't know if everyone
Oh,
knows.
sure. Yeah. I mean, fibroids are benign tumors of the uterus, the muscle wall of the uterus, and a very common thing that we see in gynecology that causes abnormal uterine bleeding, can cause like a heavy period or a period that lasts long. Sometimes it can enlarge the uterus and cause symptoms like having to go to the bathroom frequently, or sometimes it can be so enlarged that a woman who's not pregnant looks pregnant. So it's a variety of symptoms from fibroids.
And
have.
I would like to
Go ahead.
segue from this question about breast cancer right into endometrial cancer.
All right.
I would like to say this, that if you have had endometrial cancer, you probably are at increased risk for breast cancer. And
Endometrium,
some of the
Natalie,
Yeah.
what is
that's the
endometrium?
lining of the uterus, cancer, the lining of the uterus. And Dr. Patrick Anderson, I know he's biting at the bit to get to this because there's such a problem with Black women and the rise in endometrial cancer, right? So I'm going to turn that over to him. But this is one of the things I really wanted women to be aware of, that what we're doing to assess for endometrial cancer probably is not the standard, especially just using ultrasound versus doing a biopsy from the lining of the uterus. And I would expect and hope that any woman who's on here who has abnormal bleeding postmenopausal around the time of menopause will try to insist that they actually get a sample from the lining of the uterus and not just rely on ultrasound. Dr. Anderson, over to you.
Just what before the endometrium is what it gets sloughed in the monthly period.
That is correct. Mhm.
Yeah. So, the whole issue of the incidence of breast cancer after a hysterectomy, it may be too true, but not really related, because it depends on the reason why a woman have a hysterectomy. And like Dr. Roach mentioned, there are cancer syndrome where if you have your hysterectomy for a cancer and you're part of a syndrome, then you're at risk for another kind of cancer, which could be breast cancer. The other thing is, like having children, many women after they have their last child hasn't had another pap smear because they figure, well, I'm not using it anymore. It doesn't need to be addressed. Well, not because you have a hysterectomy means you should not get screened and evaluated for every other potential cancer there is, which includes a common one, breast, lung, and colon. So you need to make sure you meet your maintenance milestones. Talk to your primary care, and they need to know your history. And trust me, most primary care physicians know the maintenance milestones. So it's not that you have a hysterectomy and all of a sudden you develop breast cancer. You probably is at an average risk for breast cancer, and you develop it anyway, and it was a screening issue, right? So I think that's separate and apart. But to Dr. Roach's point, there are several cancers that are part of syndrome. So there's the breast ovarian cancer syndrome. There is the Lynch syndrome, which is, colon cancer, genetic colon cancer syndrome that includes breast and uterine cancer as well. And so it's also important to know if you fit in a specific risk category.
Mhm.
Now, the issue with Black women and women of color and uterine cancer is a real conundrum in the sense that, when we grew up, we always thought that uterine cancer was something that's hormonally connected, right? If your ovaries don't, sequence the release of certain hormones at a certain time of month, you're at risk for endometrial cancer, a certain type of uterine cancer. And that's true, but that's only for one class of uterine cancer, what we call the type 1s, the endometrioid type, the garden variety type. But then there's a type 2 that occurs, one, because I know there's a genetic risk. We just haven't put our finger on it yet, because if there wasn't, it wouldn't be such a cluster in a group of people. But it's what we call spontaneous mutations, right? And there may be an environmental factor. We just haven't put our finger on it yet. Um, it may be a lifestyle issue. We just haven't totally put our finger on it yet. But what Roach, Campbell, and Anderson knows It sounds like a law firm, right? Roach Madison. Well, we know that in our community, this GYN cancer is killing our women for the simple reason. Oftentimes, by the time they come to attention, it's already advanced. The aggressive nature of these cancers, that even in the early stage, the majority of patients recurs in the first 18 months. And there are several types of this high-risk cancer. And oftentimes, as providers, we evaluate patients based on the more common type. So if a woman who's expected to be in the menstrual age, who's 40 and bleeding clots, you don't turn around and say to her, well, you're young, you don't need an endometrial biopsy or a DNC. You do, right? The idea of using ultrasounds, looking at the thickness of the lining of the uterus, that's great for the common type. But just remember, the premise there is if it's a cancer, it grows. So it's thick and you can measure it. But some cancer can be ulcerating, meaning it's like a little sore, and it's what I call endophytic, meaning it doesn't grow out, but it grows in. So if a woman bleeds and the endometrium is normal or thin, she still needs a biopsy, right? So when you get on the internet and you read Dr. Google, and Dr. Google cite what's common, what he's not doing is putting it into perspective for you, right? What you need to understand, this symptom that I'm having is not normal. You need to bring it to medical attention. And if you think you're being gaslighted, get another opinion.
I always love getting a second opinion. I tell people getting a second opinion is always a good idea.
I always say my educated consumer is my best customer.
Yeah, that's the best idea. Second opinion. Dr. Sprott, your hands up.
Two things. One is, in this day and age, and Patrick reminded me when you talked about providers, because that 20 years ago wasn't a big term, but we have these physician extenders that don't have kind of the education or training or depth that are usually the first line that a lot of individuals see, don't see a physician. And sometimes the answers that they get from these individuals isn't the same as what the physician might give. And I just wonder whether or not that is a problem in terms of even an issue of follow-up, in terms of having non-physicians providing answers to questions, because folks don't like to say, I don't know, and may give answers that may not be necessarily entirely correct.
Yeah.
Anybody?
Yeah, I mean, I think that you raise an excellent point. And it could be, sorry.
Patrick? Yeah, any thoughts about that?
Yeah, I mean, I can touch it. It may seem political, but it's not. I think we need to be fair to the trade. I think many physician extenders, especially the advanced level extenders, are trained by us. And but there's also, I had an interesting conversation with another provider this morning who's from a different specialty concerning things that we used to do as a resident that we thought was education, but in the current environment is considered service, right? So there's a marked deviation from who has the desire to learn what and who has the desire to do what. But what I will say is, most physician extenders, whether it's physician's assistants or advanced nurse practitioners, are mentored by one of us in specific specialty. And, but we need to understand that there are limitations, right? And the limitations has to do with the oversight systems, and the limitation has to be with the individual providers, right? So for example, when I train a surgeon, I said the most important thing when you're operating is to recognize your limitation and know what to say and know when to call for help. And I would say to my physician extenders, advanced APNs or NPs, know your limitation, but there are some limitations, but there are some basic recommendations which they still ought to know. So if you're an APN or a PA who is doing primary care obstetrics or gynecologist, you need to know ACOG recommendations. You need to know those practice bulletins. They're not rules, they're simply recommendations. You need to know the recommendation of the American Society of Cervical Pathology when you make those recommendations. So, it's a good point. I don't see it as a political one. I see it as one that requires, systematic oversight as to who practices what and the level in which we ask them to become engaged.
I wasn't trying to make it political. I just know so many individuals, my friends, my relatives, they go to a doctor, they have surgery, and the person that they see is a post-op or the first visit is a physician's assistant or a PA or whatever. And they have a swelling that after 2 weeks of surgery, they ought not have. And they say, well, we'll see you in 3 months. And I'm not so sure that that's the right, and the answer that you gave us, the possible reason for the swelling, didn't make sense to me. They asked me, well, what do you think that is? I said, I'm not so sure that I know why they gave that answer. But I think that in today's, everyone is looking to try and see more patients and delegate. And I think that you're right that you ultimately are both legally responsible for those individuals that are within your practice, but the individuals may or may not know what their limitations are. And if you're not there or the review of what's going on, there are things that can slip through the cracks.
Yeah. No, I agree. I think everyone's engagement should be graded, right? So I have no issue with an NP or a PA seeing a post-op patient, but the patient had surgery for a specific pathology, and that's the most important factor, right? If I know the patient is recovering well, we sometimes charge a resident or a medical student to look at a wound and say it's healing well, right? But if I need to take a look at that wound myself at some point, I don't have to be the one to see it all the time. And if at that point, what you're telling me is not what I'm seeing, then I have a problem with you. Okay. But with respect to the specific pathology and the medicine surrounding the pathology, I think it's my responsibility.
Right. Excellent. Excellent.
And there's a question about fibroids and pregnancy that somebody on the question asked.
Oh, yeah. We got quite a few questions. We got questions lining up. So we're going to get to those questions. What we need to do at this particular point, it's halftime. And let me just go through my spiel here. First thing I'd like to do is I'd like each and every one of us to reintroduce ourselves. I didn't introduce the docs, our normal physicians, because I expected more to chime in, but it's a busy day. So Dr. Sprott, you're first. Can you introduce yourself, please? You're muted, Dr. Sprott. You're muted.
I'm a board certified pediatrician, retired for 2.5 years. I did critical care pediatrics, general pediatrics, and was the dean of clinical affairs at the medical school.
All right, thank you. Dr. Campbell, please, you're next. Unmute.
Sure. Sorry for my little technical difficulties. I'm Domelin Campbell. I'm an obstetrician gynecologist. I'm also practice addiction medicine. And as we were talking about, part of my passion is improving health literacy in our community.
Beautiful, beautiful. Dr. Roach, please.
Natalie Roche. I'm an OBGYN and also board certified in addiction medicine, where I actually take care of mainly men and not women. And I'm faculty at medical school, and I spend a lot of time doing a lot of administrative work.
Excellent. Dr. Patrick Anderson.
Yes, hi everyone. I'm Patrick Anderson. I'm a board certified GYN oncologist. I take care of women with cancer of the reproductive system. Every day I wake up and I feel so honored to be in the presence of a Dr. Roach, famous, Dr. Campbell, near and dear to my heart, Omar Bey, who I envied because his position on the wall took away where my portrait was going to be. Dr. Sprott, I used to be in fear of presenting to him in medical school, So, it's such an honor to be on the same platform with all of these individuals. And then here comes Dr. Aluya, who I'm going to let him introduce himself, but one of the smartest, most intuitive young physicians out there. It's such an honor to be in your presence. Thank you.
Thank you, Patrick. Thank you. Dr. Aluya, go ahead, take off. You're muted, Dr. Aluya.
Yes, thank you so much, Dr. Anderson. I'm honored every day to be here. And of course, in the presence of such great and amazing minds who are committed to the community and the greatness and uplifting the healthcare of our people. Nelson Aluya, medicine pediatrics trained, former CMO, NCAC, but presently doing advocacy work and in private practice. Great to see you.
Excellent, excellent. Well, thank you, everyone. Understand that every second Saturday, we're here at 1 o'clock. And all you have to do is go to OBHealthy and hit the physicians tab, sign up, and come in and ask your medical question. Please be comfortable enough to type in your medical questions, okay? The second thing I'd like to say is, and the most important thing is that please do not change any aspect of your medical care until you consult your physician. Only your private doctor or a medical specialist can truly take care of you from a medical standpoint. The next thing I'd like to say is I'd like to thank OBHealthy for allowing us to bring this webinar to you. And I'm going to end with introducing myself. I'm Dr. Omar Bey, and I always forget to introduce myself. I'm Dr. Omar Bey, pulmonary critical care and a subspecialty in nutrition. Thank you very much. All righty, we are here, and we have a lot of questions to go through. So, Dr. Sprout, I know you had brought one thing up, but let's get some of these questions answered. We have about 8 or 9 that are lining up. I think we may have answered this, but if not, then I'm just going to read through them. At what age does a woman not need to get a pap smear? I am a healthy, active senior of 82 years. I am a retired nurse practitioner. If we've covered it, let's just do a short one on it, and because we have a lot of questions to go through. Damali, is there anything we need to add to this?
Yeah, sure. I think we've had a number of people join, so it bears repeating. So in general, the cervical cancer screening, which is what we call the pap test, should start at the age of 21 for all people with a cervix, all women, whether you have been sexually active or not. You should have the pap test done. And then a lot of how we move forward is based on your history, but generally you should have the pap test every 3 years until age 30. And then after age 30, we begin to do the pap and HPV test. And then you can have the pap and HPV test every 5 years. Now, if you've had 20 years of screening and they've all been normal, then generally we are saying that you can stop screening at the age of 65. But there's a lot of little points in there. So all been normal, 20 years, but sometimes circumstances change. Partners may have changed. And so maybe you have more than one partner, or maybe your partner has more than one partner. So there may be certain specific circumstances to each woman's particular history that might change those recommendations. But those are the overall general guidelines. Those are just guidelines, they're not rules, and we really have to consider each patient's history. So for someone in their 80s, if they've had 20 years of screening and no history of abnormal pap smears and no new sexual partner, then we would typically say there's no need for them to continue to have the pap smear. But I do want to caution that it doesn't mean we say you don't need to see the gynecologist. We still want to see you on a yearly basis, because there's not only a cervix and the uterus, there's the vulva, there's the vagina. And, you know, a lot of times, sometimes the only time a patient may have a clinical breast exam is when they come to the gynecologist. So regardless of having the PAPS test, it is really important that women see their gynecologist on an annual basis.
Excellent, excellent. Let's do another question real
Yeah,
quick.
and Omar, if I
Go
might just
ahead.
add to that very quickly,
Go ahead.
there's a reason why you need to see the gynecologist because, you're still exposed to many risk factors, right? There are non-HPV related cancers which needs to be evaluated. Some of the names are the melanomas, the adenocarcinomas, which are formed in glands which are on the skin around the vagina, the sweat glands. Um, there are changes that occur in the skin around the vagina that also puts older patients at risk for those cancers. So it's not always about screening as it relates to the human papillomavirus. So you still need to see your gynecologist in spite of the need to do a pap test.
Excellent, excellent. Dr. Aluya, you have your hand up. After you, we're going to go to some more questions.
Right. So thank you so much, Dr. Campbell, for such extensive explanation. One of the biggest thing that we talk about, and again, cervical cancer, it's one cancer that's very preventable. And at this stage, especially in the United States, no woman should be dying from cervical cancer.
I think we have
Because we have
Rephrase?
I think we have a Wi-Fi
vaccines
issue.
for it.
Dr.
And oh, okay. Sorry. Can you hear me now?
Yeah, we got you now.
Right. So, like I was saying, the teaching back in the days, initially when the whole thing started, I'm sure Dr. Sprott will talk about this, was to vaccinate, young girls at age, 8 or 7, and then they now included young boys as well, even early down to 6 years of age. So it's very preventable, and no woman should be dying from cervical cancer in the United States or anywhere else in the world. Now, one of the biggest issues that we do have, because again, our women die more from the complication of cervical cancer than anybody else. Now, why is that case with all the screening and all that? It's this, that when you get your test done, anybody, you have to follow up with your test. A lot of the times, our people say, oh, we wait for the doctor to call us. The doctor has 5 million things to do. And a lot of it's the honors of the doctor. There are rules concerning this. But however, it's still your test and it's still you who did the test. So you need to follow up. As I've advised our people to do, whenever you have your test done, set an appointment in 2 weeks. Follow up with your doctor so that God
Yeah, that's a really important point,
Really
Dr.
important
Luya.
point.
And so one of the things that we have said
you don't
now,
fall through the cracks, because then you.
Dr. Luya, we're having a Wi-Fi problem. We understand.
Oh, okay.
But
I may have
unfortunately, we
my
caught most of what you said, and the most important thing is to follow up. Dr. Campbell, you were going to say something?
yeah, I was going to say, a long time ago, as Dr. Luya was kind of alluding to, is like, if the doctor doesn't call, no news is good news. But I think we have to change that attitude and really just encourage people to actually get their result. And part of the move in transparency for medical records is for people to have access electronically for their results. But if you don't get it or you don't understand it, it's still important, to be able to have a discussion, talk to somebody in the clinic. Even if you can't directly talk to the doctor, I would tell patients they can call my nurse, and the nurse can tell them if their results are normal, or if their results are not normal, then they have to come in to have a discussion with the doctor. One of the questions that's in the chat is, sometimes patients may not follow up with the pelvic exam because of the fear of pelvic pain. And I think we've all probably experienced, patients who have fear. And certainly, the gynecologists on this call have experienced patients who are fearful of pelvic pain. And so, they shy away from coming to the gynecologist. I think one of the recommendations, it certainly happens. It's important that we just try to be encouraging to patients. And as a provider, what I do is just try to get the patient comfortable. and try to build and gain their trust. So even if they come to the office and they don't have the pelvic exam on that first visit, just meeting, talking, getting them to understand why this is important. I also do this for my very young patients, or patients who may be, over 21, but have not had intercourse and they need to have a pap smear. They can be very afraid of the pain that the discomfort that would be experienced. So we first have a conversation and, I let them see the speculum, I let them touch it. I explain to them that's what's going to happen. And I don't force them to have it at that first visit. I tell them it's okay, we can reschedule and have you come in another day. Talk about breathing techniques, maybe having some relaxing music. So there are different techniques that you can use for somebody who's fearful of having a pelvic exam.
Yeah.
And I would just like to say, and sometimes this is consistent with people who have been sexually abused. So I think that if you had a bad experience with the gynecologist, change your doctor. All right. Don't not go to GYN. Get somebody else. Just because you had a bad experience with a particular doctor doesn't mean you can't have a perfectly comfortable, reasonable pelvic exam. You have the wrong provider. Change doctor.
Yeah, and I might say, Omar, standard of care is standard of care, and doing screening under anesthesia is not standard of care. But if you have that special circumstance where, to Dr. Roach's point, someone who's been abused, but really it's necessary to do that evaluation, schedule an examination under anesthesia, and be open with the patient that the reason you're doing it is so they're comfortable and you're not trying to find or get information that you don't want them to know.
Understand. All right, we have Dr. Salam. While we have a break here, I want to let you introduce yourself.
Good afternoon, everyone. This is Dr. Kareem Salam, board-certified adult and child and adolescent psychiatrist from the city of brotherly love and sisterly affection, more commonly known as Philadelphia. I belong to Global Health Psychiatry, and I'm the medical director of an adolescent unit in Northeast Philadelphia. It's a delight to be here. I apologize for joining the webinar late.
And let me tell you that I'd love to, Dr. Court, you're back with us. Unfortunately, we have a camera problem with Dr. Court, but he's here and he's been here all along. Dr. Court, introduce yourself, please. Can he hear me? Maybe not, maybe not. Hopefully he engages with us. I know that he's been having a little problem coming as far as visual is concerned. Let me get to the next question. Doctor, kindly advise on how we can mentally as well as physically from failed pregnancies, STDs, and resulting broken relationships. Okay, blessings to you all. Eternally grateful for all your counseling. So, she just wants us to give an understanding on how do you overcome some of these things, because in our community mentally, definitely it's important that we recognize that the physical, the mental, it all comes together. Dr. Salam, maybe you can start us off, and then GYN and gynecology can help us out.
Well, listen, I think this is, we live in an exciting time in medicine where the social determinants of health and mental health are part of the lexicon. I think we have a very important topic that perhaps it's already been addressed, but maternal mortality amongst African-American women.
Yeah, that's our next topic.
Well, listen, that has mental health ramifications, and I wanted the sisters to speak to the impact of implicit bias and how it affects the care that sisters are receiving and how it affects outcomes from the standpoint of maternal mortality. This is a really hot topic right now, and it's something that's certainly worthy of discussion and hopefully intervention to improve maternal mortality. And these just it's devastating the impacts this has on sisters during the birthing process, and it transcends socioeconomic status. So our resources don't insulate us from these poor outcomes. So I think to the extent that we could arm ourselves with information and really be familiar with this literature and encourage our patients to read up on these topics so that they could be better advocates for themselves in the service of being alive to raise the children that they've been, blessed to bring into this world, or at least through the pregnancy.
Excellent, excellent.
Well, I would like to address this issue just, in this way. When we talk about, equity about reproductive health for Black women, most everybody's talking about, in the general population, their desire to help us to terminate our pregnancies. What they don't want to help us to do is to have healthy pregnancies and reproduce ourselves. All right. And this is part of the racism that we have in America. So a lot of these bad experiences that people have around pregnancy loss really come through that lens. They're happy to end your pregnancy for you, but they are not happy to assist you to have a healthy pregnancy and a healthy baby. And this is racism in America. All right. So when you go to the hospital, go to your private doctor, whatever, and miscarry or whatever, they just go through the mechanics of taking care of your physical health and won't do one single thing to help you in terms of your emotional healing and addressing your grief. All right. And that's where you're left with some post-traumatic stress disorder from engaging the system around issues about reproductive loss. All I can do is think about that poor woman who we just saw in the newspaper had the 21-week loss in the state where abortion is illegal, and they sent her back and forth. She miscarried at home, and then they arrested the poor woman for abuse of the fetus. Can you imagine what that poor Black woman was going through? She can't even miscarry her second trimester loss in peace without being engaged in the legal system. So this is where our women are. They are hurt all the time within the system. What we ask you to do is understand that there is a patient bill of rights, and understand that when you go and address the healthcare system around your reproductive issues, you need to go understanding that the legacy of racism, understanding that you need help with advocacy for yourself. Don't go there alone. Bring somebody with you. You need assistance, you need people, you need support. And then understand that your grief over your pregnancy loss is a valid thing, and it must be addressed. And do not let people dismiss you and dismiss your emotional trauma.
Excellent, Natalie. Excellent.
Yeah, I would just add on to that. And it really, unfortunately, I think that oftentimes in our communities, people may be thinking that they're trying to help by saying, well, you were only 8 weeks or you were only 10 weeks. But you know, people may bond with their pregnancy at different points. So when you miscarry, a loss is a loss, and it doesn't matter really whether it's a first trimester loss or a second trimester loss or a third trimester loss. Dealing with the medical aspects is one thing, but dealing with the mental and emotional grief of the loss of that pregnancy is valid and is important. And there are organizations that help to deal with that. And, actually in New Jersey, we do have, an organization that advocates for people to be given resources, such as some of the grief support groups that exist. I don't think that we're monitoring how often that is happening. And we know there are great disparities, among persons of color, and oftentimes persons of color may not find that all of the support groups are as diverse, and may not always be as understanding to their particular issues. So, we still have a lot of work to do in that area.
Mhm. All right, thank you. Dr. Aluya, your hand's up.
Yes, thank you. This is so profound because it's a two-way thing. Often enough, they look at the medical literacy rate and the exposure and everything else, the Black community, and um, in one way dismissively say, hey, you guys should take responsibility for yourself and take charge of your health. Yes, we need that. However, on the other flip side, it is something I'm actually talking about lately. Is medical gaslighting. And this is a term that's coming to the medical lexicon now, and we need to take, pay attention to it and the cognizance of it. A peer review study that came late in December, and I posted it one or twice, that said, the coming year, 60% of Blacks are prepping for insults from a healthcare provider, as compared to 33% of whites and 51% of Hispanics and 43% from Asians. And that's the insult that they get from healthcare providers. And once you get in a place where it's hostile, it's harsh, and you can't talk and you get dispelled or you're made to look like a fool or ignorant, the chances of you going back there to that same provider will be nil or none. And even if you do go, then it's hard to comply. These are some of the issues that we must address. As a matter of fact, I'll be giving a talk at Beth Israel on medical gaslighting and how to addressing this issue of healthcare disparity in our community, because this is still something we need to begin to address. However, one step to addressing that is for us on our own to raise young Black men and women who we need to go into the medical field. Because listen, you're most likely to do well when you're taken care of by people who look like you, period.
Yes. Dr. Sprott, thank you. Go ahead.
I think this whole issue of access to mental health care is pretty abysmal. And I think a lot of it relates to the way that physicians are reimbursed. They're not reimbursed for their time as it relates to counseling. And almost every doctor that you try and get an appointment for, you can see some of the delays and how soon you can see a physician of a particular specialty, but they don't pay for the time that gets spent in counseling. Adolescent medicines, they spend a lot of times, the adolescent patient doesn't have a lot of medical issues, but a lot of times they have psychological issues, and the insurance companies don't want to reimburse for the amount of time that it takes. Certain specialties in endocrinology that takes a lot of time to help understand about that, they don't want to reimburse for it. And so, especially if you are poor and your insurance companies don't pay a lot anyway, the ability for you to see a psychiatrist or a psychiatrist, especially one of color or that looks like you, is extremely limited. And physicians, I don't care where you are, where you practice, in some shape, form, or fashion, are going to be on the clock. You can see how much time is allotted when you go for an initial visit or a follow-up visit, and they'll start to split the visits. And so if you really have grief and you need some counseling, God bless you if you can find someone who will see you in a timely fashion. And it doesn't matter. And again, you talked about maternal mortality. It doesn't seem to be that specific as it relates to whether or not you have money or not. If you have money, sometimes it's extremely difficult for you to see. You talk about a Black psychiatrist or a Black psychologist, they're few and far between. And so I think this whole issue of women that have suffered loss, or even men that have suffered loss, their ability to get counseling is one thing, support groups, but to have professionals that to help guide you through it or take you through it and not just put you on medications is very, very difficult. And I'm not sure that it's an easy fix. But I know that, a lot of psychiatrists only accept cash or accept the best of insurance. And so think of people that don't have very good insurance that pays. It's difficult. And so we have, social workers that can do some counseling, and they fill in the gaps. I guess within the last 20 years or so, the qualified health centers have started to provide some sort of counseling, but it's still not adequate for the need that's out there.
Yeah. Dr. Salam, I'm sorry, I didn't mean to cut you off.
Listen, to further highlight Dr. Sprott's point, pre-COVID, the situation with child and adolescent mental health was, it was a dire emergency. And then the level of emergency since COVID is beyond description. So brace yourselves for what I'm about to say, but Dr. Sprott is actually right. I know colleagues, I'm constantly getting calls from colleagues who are looking for therapists for young people in their family, oftentimes promising young people who need help. And, you know, they want someone of color and they don't want to get stuck on someone's wait list. And the remedy to that, sadly, is, you know, you have to be willing to pay out of pocket. And it's not only psychiatrists who adopt this model, psychologists as well. And those are the most highly trained and highly skilled mental health professionals with the most experience and who are best equipped to treat those with the greatest clinical needs and the most acutely ill mental health patients. Also, you could be very skilled in navigating the whole medical insurance complex, but still be unsuccessful in getting your medical insurance company to reimburse you for this cash outlay. But that sadly, that is the remedy, and it really forces folks to face their priorities. So folks seem to, you know, marshal resources for, you know, whatever sneakers their young person needs, whatever fad is available. But I can't think of too many more things that are more important than a young person's mental health, especially in the setting of a crisis. But sadly, that's where things are. I don't know how that's going to change. And we all have needs, even medical professionals. We all have mortgages, we have livelihoods to, and we have families to support. So, you know, sadly, that's the payment structure. That's the system we have. So that's what we have to work with.
Thank you. Dr. Campbell, your hands up.
Yeah, I just, you know, appreciate all of these comments, and I just wanted to circle back to Dr. Salam's point in thinking about maternal health, particularly because in January 23rd is a day that we try to highlight maternal health. It's January 23rd, 1, 2, 3 for mothers. And when we talk about mental health issues, and we think about pregnant women, pregnant individuals, and the postpartum period, you know, the postpartum period is really in the United States considered up to an entire year after giving birth. And so when we put this all in perspective in thinking about mental health issues, you know, the CDC looked at 9 maternal mortality review committees, and the vast majority of maternal deaths actually occur in the postpartum period and are related to mental health issues and, of course, cardiovascular diseases. And so, you know, this is an extremely important conversation that we have to have, not only about pregnancy, but about the postpartum period. Not only because, you know, not just the 6 weeks, the 42 days that people traditionally think of as that postpartum period, but for the entire year postpartum, because having a newborn can be overwhelming. And so we have to think about how to better support our postpartum individuals and their families. And, you know, when and if a mother suffers morbidity and mortality, yes, that is a terrible thing for that individual, but it's actually a ripple effect where it affects so many more, right? It's not just that one individual. And of course, the loss of any individual, you know, is immeasurable. But we're not just talking about the loss of just one individual. There's a ripple of effect of the father, of the child, of the rest of that extended family that is dealing with that, morbidity or that loss.
Mhm. Excellent, excellent. Dr. Aluya, you're first, and then Dr. Sprott, you're going to come next.
Yes. Adding to what Dr. Campbell, had just said, as imperative that we pay attention to maternal mortality death rate because the effect is so much more on the family than and not just ripple, but it goes on for generations. Now, I know, like you said, looking at the breaking down the data and all that, and I love data and I look at this. Globally, the maternal mortality death rate had dropped within the last decade. It used to be about 800 in the 70s, dropped down to about 500, and right now it's about 450 globally per 100,000. Now, if you drop that to the United States, presently it was like 38.1 per 100,000. Now, if you drop it down to that increased or decreased, with COVID. Now, if you drop down to Jersey is about 40.1 per 100,000, one of the highest in the country. Now, if you drop that down to our locality where we live, where the Black and brown community live, in Jersey, Essex County is about 100,000, 100 per 100,000, 100.2. So it therefore means that our numbers, as it goes with everybody else saying our numbers are 4 times what everybody else is, that's the truth. Now, what is the cost of death for our women? And one of the things that we must advocate for is to dispel this whole narrative when we talk about mental health. Yes, it's a big issue, but if you break it down to what is the cost for our women dying, it's not mental health. It is still cardiovascular. Number one, cause of death among our people. So when we advocate and we talk about mental health issues still big, yes, but when it comes to people who are all like us, we need to focus on what the issues are and what we are dying from. And that's why we would advocate for where to put that money into. For instance, one of the ideas I had one time, because that's the reason why and I've seen young women who die, no mental issues, great support, educated and all that, and they just drop down and die. Close people to me, friends and family friends. Now it's to see, hey, understanding that our young girls, first pregnancy, often have high blood pressure or eclampsia or preeclampsia, and even develop preeclampsia or eclampsia after they even delivered. Knowing that 30% of them, mortality happens, in pregnancy, but majority of the rest post-pregnancy. Now, if you look at that, one of the suggestions, I'm sure maybe somebody here will take that on, is to have an ultrasound for every pregnant woman who's Black in the United States. Maybe that's what, so that we can identify those issues that affect the heart early enough in our community. How many of them are dying from aneurysms that we don't even know of? So these are issues that as we address this issue, as everybody else address theirs, we need to address ours as well. Thank you.
Really quickly, Dr. Aluya, I'm not sure we could divorce these cardiovascular complications from the mental health impacts.
Yeah.
Speaking to, is it Dr. Roche? Yes. Just this whole phenomenon of weathering and the impact of implicit bias, systemic institutional racism,
that's the word,
being black in America over a lifetime weathers you. And I think it's an interlocking relationship between this physiology and it happens to wreak havoc on these sisters' bodies through the cardiovascular system.
Absolutely.
Right? And it's not just women. How many of us know our friends, Black men, who've been on antihypertensive since their 30s, right?
Yeah.
So I don't know. I think it, I think their physiologic impacts of the African Americans or the Africans' experience in this country. You even see it in African immigrants, folks who have no hypertension, and they come to America, and you become a Black person in America, and all of a sudden, right, you're on hydrochlorothiazide, right? So I think it's hard to separate the two.
Yeah.
If I can just jump in,
Yeah.
I know Dr. Sprott is patiently waiting, but I just want to just be clear, and this is why I said not only mortality, but morbidity, okay? Mortality and morbidity, because the people, we have to think about morbidity, which happens, morbidity means that you have a problem, but you lived, right? And that is occurring 10 times to the extent of the people who are actually dying. And, so yes, you are right. If you look at the cause of death, the number one cause of death is cardiovascular disease. But you got to be careful when you start comparing globally, because most countries are not looking at their causes of death for an entire year. They're only looking at that 42 days. And so, I was very careful about expressing the 42 days, which is our traditional postpartum period. And that's where we get our WHO definition of maternal mortality. Okay. But when we talk about the United States, we're talking about for the entire year. And most countries don't look at an entire year. You rightly brought up our New Jersey statistics. We better be careful, because there are people going around saying New Jersey went from 47th to 25th. That may be the case, but we do know that the disparities that are seen for Black women in New Jersey are persistent, and they have been persistent over several decades. And so if we're not paying attention to Black women, we're going to lower maternal mortality in New Jersey, but it's not going to change for Black women. And one of the first things that we can do in relationship to cardiovascular disease is making sure that Black women, particularly almost all Black women who are pregnant, may meet the criteria for being on a baby aspirin during their pregnancy. And this prevents preeclampsia, and it also prevents preterm delivery, because a lot of women get induced because of gestational hypertension, pregnancy-related hypertension, and preeclampsia. But we start a lot of women on aspirin, they start taking it, and then they say, I don't have pain, I don't have a headache. You're not taking it for a headache. You're not taking it for pain. You're taking it for the prevention of preeclampsia. This, is something that we can do today.
Excellent. And that's excellent. Dr. Sprott, your hand's up and you've been patient.
Yeah. So I think, having listened to the discussion, I think there are a couple of different issues that come into play. And one is sort of the definitions in terms of maternal mortality and when it happens and why it happens. When you die, you have to die of some reasons, and it's going to be either the lungs or the heart or blood loss or something of that area. And I think that initially when they started to look at it in terms of reducing, it really had to do a lot with both preeclampsia and then blood loss after the pregnancy, that women that weren't being watched and monitored. And some states put together protocols that were able to address that blood loss that were greatly brought it down. But I was thinking, in terms of what you said, and I don't know what the routine is. I'm married to OBGYN, but indeed, I don't think that the follow-up after the woman delivers it and at the obstetrician is very great over the course of a year. Very different from the pediatrician. The pediatrician sees the baby after the baby's born at a week, a month, 2 months, 4 months, 6 months, 9 months, a year. And I think that if there was some kind of collaboration, the American Academy of Pediatrics, to have pediatricians ask the mothers when they're bringing these kids in for the normal visits about their mental health issues, that then the issue then comes, if it's raised, then what do you do with them? who do you refer them to? The pediatrician is taking care of the child, but you can't take care of the child unless you're taking care of the mother. Because if the mother's not paying attention to the child's not going to do well. But the pediatrician may be able to recognize if they ask the questions and they get answers. But the question is, how do they then get them to someone? Because they don't necessarily make referrals to mental health specialists for the mother. But that's something I think that could be done that might address some of those longer term mental health issues. Because you're right, Kareem. I mean, that you can't separate the mental health issues from all the cardiovascular and the other issues that occur. But it might be something that a group of pediatricians in relationships to the people that are concerned about the long-term mental health mortality could maybe help to recognize, address, and get them referred to someone that can see them and help guide them through this process.
Excellent. Dr. Anderson, we're going to let you go next, but after that, we're going to try to tackle some of these questions before the time is gone. Go ahead, Patrick.
Yeah, you got it. It's an interesting discussion, and it's clear that the issue is multifactorial. But I would say this, I think the basis of some of this problem is an intrinsic bias that's one rooted in racism, but also rooted in how we're taught, right? Remember, clinical trials are important, and many of the standards that we see in medicine, like what constitute a normal blood pressure, how many people of color in specific circumstance, pregnancy, age categories, were part of these studies that established these standards. And so that's one part of an intrinsic bias that's built into how we're taught and what we're learned as providers, right? We somehow take just one value and make a big deal out of it. Well, we need to understand patterns, right? So the consistency of who sees patients help with this intrinsic bias. Then there's the bias of what I call being pressure treated, right? Everyone expects people of color, you've been there, you're so pressure treated, your pain is really less than how I interpreted coming from somebody else. So that young sister who shows up and say, I get a little chest pain, and you say, well, it's just a little gastritis, right? Because you don't eat right. Well, guess what? She really is telling you that something is going on in her chest. It may be a subtle MI, it may be a clot, but we don't listen it enough. And that speaks to intrinsic bias. So I think, many providers really, unlike the doctor, you don't have to tell them where Dr. Roach lives. I know where to find her because she's in the community. Same thing with Dr. Campbell, Dr. Salam. He didn't have to advertise that he's in the sister city of brotherly love. We know where to find him. We are connected to the community. We live among the people we serve. Many of our providers, 80% of them, come and go. The sun comes up, they're there. The sun barely goes down and they're gone. So they're really not connected to the community, and they're not hearing what the people of the community are saying. They're not feeling the complaints. We have a way of hearing it, feeling it, and understanding it. And we pay attention. And that, to me, is the basis of the intrinsic bias. I tell you, I myself did a study looking at women of color and their outcomes in type 2 endometrial cancer and the use of technology in managing those patients in an institution where the primary provider is a person of color. Well, guess what? I still treat my own people differently. Now, there may be some other reasons, and I'm not trying to justify it, but there's that intrinsic bias that even us who lives it is starting to believe it because we hear it so much.
Excellent, excellent. Great point, Patrick. Great point. Let's go to a couple questions. Fibroids. Are there preventive measures for these particular problems? I've had surgery and they have returned. Is there anyone that can approach this? Had surgery for the fibroids, they've returned. Patrick, can you help us?
The problem with fibroids is the ones that we treat are the ones that we see. The problem is the changes have already occurred in many of these cells and we're just not seeing them. The other thing is there's a genetic basis that, unlike cancer, where we know how to use genetics to tailor treatment for cancers, we haven't figured out how to use genetics to tailor the management of fibroids. So there's still a long way to go. And as long as I've been in this business, I don't want to take on the shame, but I have to say as a provider, we have not paid the kind of attention to fibroids like we do cancer, understanding that fibroids is as devastating, as disruptive to the life of many women, and especially since the majority of women who get fibroids are people who look like you and me, we just have not paid enough attention to the cause and the management of fibroids.
Mhm. Excellent, excellent. The next question. Please discuss the recommendations for hormone replacement therapy. I'm 48 years old and already in menopause, 2 years so far. Various types or pros and cons, please. Can we?
I can start off with that. Yeah. I
Okay.
mean, so hormone replacement therapy, again, individualize that conversation with your provider. And typically, what we're talking about is the symptoms. And some people, they may go through menopause and, say, I barely had any symptoms. Let's go back and talk about what is the definition of menopause. And so the definition of menopause is not having a period for an entire year. Not having a period for an entire year. And so, and typically for most women, the average age of menopause is around 51. So we will see that some women may go through menopause in their mid 40s and up into the early 50s. But a lot of the treatment really depends on the symptoms that the person is having. There are other women who experience menopause and there are numerous symptoms. They may experience not only hot flashes, but mood swings and headaches, difficulty sleeping, vaginal dryness, difficulty with intercourse because of that. And so we have several types of hormone replacement therapy, oral replacement therapy. We have the what we call transdermal, which is a patch that can be placed on the skin. And then we also have a vaginal estrogen that can be placed either by a pill or by a cream. I know a lot of people, a lot of women, you look on the internet, and maybe some different studies come up about hormone replacement therapy. I kind of got a bad rap after the Women's Health Initiative study. But what we do know about that particular study is that the women they started on hormone replacement therapy were much older than the typical women that we would start hormone replacement therapy on. So of course, those women who were in their 60s had a lot of complications from the hormone replacement therapy, a lot of cardiovascular complications, and what we call thromboembolic events, blood clots, and things of that nature. But typically, it's very unusual for a 60-year-old to come and request hormone replacement therapy. We are typically, patients are coming for hormone replacement when they are going through menopause, when it's new, when they're experiencing the height of their symptoms. And so it's a discussion, it's a risk and benefit analysis based on the severity of symptoms. I'll stop there.
Mhm. Excellent, excellent.
And I would just like to say one thing. Be sure
Go ahead.
that while you're addressing your issues of your perimenopause or menopause, that you have a good general physical exam. One thing you do not want to do is start to treat menopause and find out that it is your symptoms are actually not from menopause. Most of the time, you're going to be able to figure that out and understand it to be true. But a lot of people have thyroid disease and it gets missed in this shuffle. All right. And people will be mismanaged. So you need a good general physical exam. You need some basic milestones in terms of primary care labs.
Mhm.
Make sure you're not a new onset diabetic or somebody who's hyperthyroid or hypothyroid, and then proceed to figure out if that's all ruled out, what you're going to do about your menopausal symptoms. And hormone replacement, a lot of people are reluctant to take it, and a lot of doctors, unfortunately, are reluctant to give it, which I think is inappropriate. But remember, the rule of thumb is you go on it and you stay on it for the shortest period of time. All right. So again, but I remind you, make sure you have no other medical problems that could mimic your menopausal symptoms.
All
Yeah,
right.
and I,
I
and
know
I
that
might I might
I
say real quick, it's not one size fit all. And to Dr. Roche's point, you use the lowest dose, if lowest effective dose for the shortest period of time.
right.
But we also must consider, understanding risk factors, right? If a woman is at risk for cardiovascular disease based on family history or known genetics, hormone replacement may be for her, but not necessarily for her church colleague who, can manage those symptoms through alternate means. There's pharmaceuticals and there are plant-based products that alleviate symptoms, but from a physiologic perspective, you have to consider the consequences of menopause, right? We see it as natural part of aging, but your cardiovascular risk goes up, your orthopedic risk goes up, and all the other things that Dr. Campbell mentioned. But if you are at risk for a consequential terminal illness as it relates to menopause, then you may be someone, in spite of the chatter as to side effects and risk of being in menopause, should be on hormone replacement therapy.
Mhm. Excellent, excellent. Can we just go to another question real quick?
Yep.
Um, if a woman has fibroids, can she have a child?
Yes,
All right.
definitely.
Good.
Many women get pregnant and go to full term with a fibroid or with many fibroids. But again, ideally, that would be evaluated before pregnancy. For women who have fibroids and are trying to get pregnant and have been trying for some time, they probably should undergo evaluation. Occasionally, there are women who may need to have specific therapies or surgeries to remove fibroids as it's related to infertility, but we see many, many women with fibroids who get pregnant.
Okay, good. Next one. Also, please share any tips for nutrition to help with menopause symptoms like the hot flashes and palpitations and heart care. Is there are there any natural medicines or anything like that that you hear about or that your patients are taking?
I know that a lot of that sometimes people talk about natural medications, but I think as Dr. Anderson was alluding to, these plant-based, they are bioactive. So they the they still have a hormone. It's just the hormone is plant-based as opposed to synthetically made in a lab or made from horse's urine. Patients always don't like to hear about the horse's urine for their estrogen therapy. But it is amazing to me how people go to providers and allow them to inject pellets of things in them, and they don't have any idea what is in these pellets. People tell them they're bioidentical hormones, but they don't really know what's in these pellets. So I would be really careful with those.
And
What
I would
about
like
you?
to say, you are what you eat, and you are the amount of exercise that you get. You're also how much you weigh. So the perimenopause and the menopausal period is a time where people tend to start to gain weight, and whatever bad dietary and exercise habits, which is usually for exercise, is lack of, this is the time to address all those issues. All right. If you can clean up your diet, if you can get some exercise, if you can do the best you can to avoid that, 5, 10, 15, 20 pounds of weight gain, the whole process of perimenopause and menopause goes much easier. There are food triggers. Alcohol. We don't recommend any alcohol. You drink, you will flash. All right. For most people, that is true. Sugar. Dr. Bay will talk about is how sugar is a poison, right?
It sure is.
Excessive sugar intake, you will flash. Metabolites of cheese, you have to be careful. There's some things. So everybody has certain dietary triggers, but alcohol and sugar are huge triggers. And this is where we have to try to address the basics. A good Mediterranean diet, adequate hydration. Dehydration is also the enemy. Avoiding weight gain and getting adequate exercise is the floor. It is not hormones, medications. That's the floor.
Excellent, excellent. All righty. I know someone had their hand up, and I had skipped over them there. I don't want to skip over anybody. Did anybody have any added anything
Yeah,
added?
I did have my hand on, and it was about the issue of perimenopausal and menopausal period. It's
Mhm.
just like, when they came up with the definition of pre-diabetes, with all the attendant effect that takes place out of it. The perimenopausal period and menopausal period is a state of hyper-inflammatory process. And, Dr. Anderson just said that, the attendant effects of cardiovascular risk and what do you call it, orthopedic risk involved with, menopause itself. I think it's a disease in itself. And the question is, I don't know if there's any studies that have been done, particularly on menopausal, the outcome of menopause in our community, if that's been done, and how has that increased the risk of heart disease or cardiovascular disease in our women, understanding that a lot of women who die often die in the 50s when they become, postmenopausal. And that's when the risk of cardiovascular risk tend to really increase and go really high up. So again, exercising, reducing alcohol, watching your diet is paramount with that.
All right, excellent. Let's go on with we got quite a few more questions to get through. Here's another one. Well, wait a minute. Oh, did I do something there? Hold on just for a minute. I'm not a computer person here. Okay, let's try this. There was a question there that and unfortunately I clicked it back. How likely is it for a woman to have a negative HPV test for over 20 years, then become positive for HPV? I know we
Part
had
of it may
talked
be
about
related
HPV.
to new exposure, new partner,
Yeah,
if possible.
it's
Mhm.
certainly possible. Yeah. I
All
agree.
right. All righty. Let's see. Good day, all. I am so glad to be able to join this monthly session. Today's topic was awesome and might deserve a part two. How you like that, guys? In addition, would you would love to have a session for men's health as well, and we'll think about that and obviously think hard because it's going to happen. All right.
Well, men's health start with women's health, right?
Say that again.
Men's health start with women's health. This is where it
That it
starts.
does.
This is where exactly where it begins.
Okay, here's another one. Hypothyroid and perimenopause
Mhm.
have similar symptoms. I was misdiagnosed, and we just talked about that, right? As far as getting a general medical exam before being before being diagnosed with menopause. Um, is there anything else we want to say about that aspect? We covered it pretty good. Any further?
I mean, I just think in general, for many women, their gynecologists actually function as their second primary care physician because
Mhm.
when you
Sometimes
look at,
only primary care physician.
yes, especially for young women. So when
Mhm.
you look at many of our society's practice bulletin, I would say the majority of them bears to evaluate primary care issues, cardiovascular issues, nutritional issues, weight gain, and so on and on and on and on. So for many women, their gynecologist, doubles as their primary care. So
Mhm.
hardly anything should be missed when it comes to healthcare and wellness.
Mhm.
I
All
like
right.
to think of it as kind of a checks and balances, I can see a patient and say, have you had your colonoscopy? Have you had, go through the immunizations? That, we often talk about immunizations, and we think about kids, but there are immunizations that we should have as older adults.
Mhm.
The flu vaccine, the Shingrix vaccine, which is for,
Shingles.
for varicella,
Mhm.
to prevent that recurrence of I said varicella, sorry, for herpes,
Yeah.
the pneumococcal vaccine. And So, I like to think of it kind of a checks and a balance system.
And the COVID vaccine as well, right?
Yes, sir.
It's shifting away from the
Well,
boosters.
what I would like to recommend is that the patients actually be educated consumers. You can Google what are the primary, say whether you're male or female, what are the primary care screenings that I should have at age 40, 45, 50, whatever. And you really have to advocate because this is part of that unconscious bias. I see this all the time. I work in a place where there's subspecialty medicine, and most people have primary care. And I spend a lot of time doing colon cancer screening, low dose CTs for people who meet criteria. And I'm the gynecologist, and they've seen 2 internists, and it has not gotten done for Black patients. So the patient needs to actually go into the office with an understanding that I'm 40 and these are the things that I'm supposed to have, as a 40-year-old, and advocate for yourself because you cannot, based on my experience in the healthcare system, taking care of people, as a Black person, caring for Black people, lots of stuff that are primary care milestones are missed, particularly colon cancer screening. They're not going to want to go. And they actually may ask once, don't explain all the options available, and the people end up not getting the care. I'm on a first name basis with the GI people. That's how many people I send for colon cancer screening. I managed to get them to go because I explained to them it's not all colonoscopy, the range of things that they can do. And I seem to be able to get them to go. It takes effort. The problem with us when we go to the doctor who doesn't look like us is what extra effort it takes to explain, to advocate, to ask again, annually. And I get everybody to go because I don't give up. I keep on talking and talking and talking until they finally get there. All right. The effort, is not made. And so even when you're cooperative, sometimes you will not be offered every test. This consumer has to be their own advocate.
Right.
One other question, our EMRs actually highlight some of the things that we ought to be doing for patients based on age and documented risk, right? Because you can do data collection in real time with some of these more sophisticated EMRs. So, for example, now we're using Epic and a storyboard on the left side, it's telling you, be considerate of, consider the colonoscopy, the lung cancer screening, the HPV vaccine for a particular patient of a particular age. So one of the things patient can simply ask, and it may seem out of the box, but say, hey, doc, what is my records telling you I need?
Listen, we're running low on time, Dr. Sprock, and then
Yeah,
we're going to go with Dr. Campbell. And there's one more question. Go ahead, Dr. Sprock.
Yeah, just on this very note, I had a classmate that died suddenly of a heart attack. He had stents put in 2006. He saw a cardiologist twice a year. He had no evaluations other than the EKG from 2019 until 2023. And the issue is that the same underlying conditions that caused him to have the need for the stent in 2006 continue. So he had complete occlusion of his main coronary artery and 2 other arteries and hadn't had any kind of evaluation to see whether or not they were patent. And the fact that he didn't have much in the way of symptoms didn't stop him from having this heart attack. And he could have easily had studies done that could have shown that he need to have some additional stents put in. So you just can't assume that you're always going to get. I have a cousin who had stents put in around the same time. He has evaluations twice a year, and they look at his coronary arteries to see about the patency. So you just can't be sure that the person that you're going to is going to do the right thing, and you need to be aware and advocate for yourself to make sure that something like this doesn't happen.
Excellent.
Yeah, and along those lines, I was just going to say, we talked a lot about some of the factors that go into some of these disparities. I think, Dr. Salam was trying to bring up the implicit bias and how that plays into a lot of disparities that we see. And maybe your part 2, we really need to drill down on that specific, thing. But I think to many of the points that I've seen here, having somebody with you, if you're able to advocate for you, having some questions, because you know, a lot of times you get intimidated when you go to the doctor and you forget your questions. Write them down before you go in. Have a little index card and write your
Put
questions
them in your
down.
phone.
Put them in your phone. Thank you. You know, and be ready to ask those questions. Don't be afraid to ask for a second opinion or to go for a second opinion, because sometimes that's going to be what is necessary. I think that's really, really important for us. Because the reality is, and I'm the president of New Jersey Medical Association, as Dr. Bay said, when he introduced me, and many of you here on the call serve as mentors. But the reality is, while we are 15% of the population, we are only 9% of the physicians in the United States. So
And
when
that may be
we're
a high
looking,
number.
and so when we're looking to have a physician that looks like us, first of all, I need some of you on this call to send your kids to medical school. I really need you to do that. That's because every time I just filter emails after emails after emails asking for a primary care doctor, for a pulmonologist, for this adolescent type of person in X, Y, and Z county. And, you know, sometimes the person is there, but sometimes we don't have a provider that looks like us. That doesn't mean we can't get good care. It means we're going to have to work a little bit harder for it. And part of working a little bit harder for it means having those questions ready, you know, educating ourselves, having those questions ready, and not just accepting everything at face value, but just saying, hey, doc, I didn't get what you said. I need you to explain it a little bit further. I need you to break it down.
Excellent. Dr.
So,
Salam.
so a long time ago, I learned when you're Black and you don't speak a lot, the assumption is a lack of knowledge. So I would, to Dr. Campbell's point, make up questions, right? So people know you're verbal. Not only that, questions convey a message that you're alert, and it may tell the provider you're being watched. So, you know, we all behave better when we know we're on the camera. So, and finally, with implicit bias, folks are not treating people who don't look like them like their own son or daughter. They don't see themselves in the folks that they're taking care of. Okay. And we do. Okay. So, you know, I'm taking care of Nana, or I'm taking care of my son or my daughter, because, you know, so that's what it all boils down to. And before folks became physicians, they were human beings a long time for that, prior to that, with biases, right? But the literature is replete with examples of how folks are more adherent with primary care recommendations when they come from a provider that looks like them. So anyway, sadly, that's how folks are behaving. They don't see themselves in the patients that they're caring for when they don't come from the community.
Right.
Yeah, just
Sorry,
to
if
quickly
I
put
may,
into perspective, you know, Dr.
if I may
Campbell
add
and
a
Dr.
little bit
Roach.
to that. And that's why we talk about first we must organize.
Right.
And I'm glad Dr. Damali Campbell talked about the role of associations and what associations can do in bringing medicine to the community and to the people who are in the community and people who serve the community, whether they look like the community where they serve or they don't, because we have to hold them accountable as well. And doing that, meaning we have to reach out to them, connect all the dots within all of these spaces, within those who look like us and those who don't, so that they also know they're on camera and we're watching for out for our community. And as we do that, we'll also educate our community as well, and the members of the community, and saying, hey, this is what you need to know. This is how you need to know it. Two, reach out to other organizations as well. The clergy is huge. I mean, we see what they did with civil rights and everything else that will come. We need to call upon them again to say, you know what? This is dire. It's important. We need your help to put this word across to our patients so that as they trust you, they can also trust us. And as well as that, raise young ones who will teach, who become advocates in the community. And I say this, that each and every one of us must take charge and leadership of our individual spaces and find innovative ways in answering questions or solving problems in those spaces. I'll give you a typical example. Clinical research. Dr. Spratt just talked about his friend who died from heart disease, irrespective of what they've done, multiple issues. Now, but guess what? Their research is showing now that it's not just looking at the cholesterol, but looking down to the details of the cholesterol, which we know, but looking at the type of the HDL and the LDL type, and we have to measure them. We're talking about APB43, APB100 that are higher risk that we need to measure when it comes to heart diseases. And that just measuring just the LDL alone is no longer enough. The question is this: who is standing in the gap for us in that space on research so that they can transfer this and come back to us and say, hey, you need to do this? Because one of the things they always talk about is like, oh, well, we as Black people, we carry a gene that reduce the APOA1 lipoprotein for us, but that may not be true. Is it the food or something else? So we need to raise people who stand in the gap for us at every level. And that's what I'll say. Hopefully there's a part 2 of this so that we can discuss.
Dr. Spratt, we've run over time, but I'm going to give you it. I'm going to give you the
I just
last
want to make a plea for folks, and that is, even though you might not have a doctor in the family, if you do have a doctor in the family or a nurse in the family or someone that's in the healthcare profession, you need to use those individuals as resources because they may know someone that you are better connected to. And they may know what questions you need to ask, or they may know that you need to ask this, or you need to bring this, or you need to do this. I can't tell you, how many of my friends and relatives call me and ask me stuff. And I've even talked to the doctors. There's when I talk to a doctor, it's different than what they want to know about you and what you know, and they act and behave differently. So if they know that there's an advocate who knows something that you can bring even on a phone call, if they know that you're paying attention, they will behave differently. And so we need to extend ourselves, and your family members who have that kind of connectivity that can reach out and say, hey, I don't know, let me talk to this person. They can help with these visits and improve your ability to receive better care.
Excellent. This has been a wonderful webinar. And I agree, we have to do more like this. Dr. Campbell and Dr. Roach, I just feel so proud and I'm just overjoyed that you would come on and express your knowledge the way you did. I mean, wisdom, knowledge, and understanding to me means everything. And that's what we must portray and expose, that kind of, our patients should understand that. Also, in letting our patients know that they have to advocate for themselves is so important. And I think you've expressed it, each and every one of us, of you have expressed that so nicely. And I trust those who are listening has taken it to heart. Don't assume. You know what Felix Unger used to say about assume. So do not assume that the person sitting across from you, because they have an MD, is doing everything they can do to make sure that you're healthy. You have to advocate for yourself. And it's just been a wonderful webinar. I'm looking forward to having you guys back, and we're just going to keep doing things like this because our community needs it. All righty, it's time to close. So all I have to do is say thank you to OBHealthy for allowing us to bring this webinar to you and supporting us. It just couldn't be done without them. Remember, every second Saturday we're here, all righty, and it's at 1 o'clock. All you have to do is go to OBHealthy, click on the physicians tab and come in, sign in, and come in and type in your medical question. Just to let you know, going forward, we are changing the name of the webinar from Physicians Health Network to the Doctor's Lounge. And the reason, and let me explain the reason for it. And, uh, you know, what we do here is to come in and really talk to each other as though we're sitting in the doctor's lounge discussing a medical problem and how we're going to take care of it and what best we can do for our patients. That's how we do this. We come, it's not in an isolated, kind of cocoon. No, we integrate and we talk to each other and we really come together to see how we can take care of our patients better, just to do the best medical care that we can. So that's what this webinar is. We feel that we want each and every one of you in the audience to have that type of feeling that you're comfortable enough to come and type in your medical question and know that you're going to get an honest answer from a Black doctor that really cares about his community and his people. Understand that this is why we're here. We're here to educate our people about health. So the name will change. All right.
Omar,
And
just
that'll be
quickly,
going forward.
say the
Yes.
other reason why you started this, right?
Oh,
Remember,
yes,
we're
the
going over
second
this.
reason,
Right, Dr. Campbell reached
which
out,
is probably the most important reason, is that we're encouraging, shouting to the loud. I'm on a chandelier shouting that we want young brothers to think seriously about coming into medicine. In about 10, 15 years from now, we will have a hard time finding Black males in medicine. It's unfortunate, but it's true. And we need to rally call in each and every level of medicine, letting young African-American, put it this way, young brothers that are of African descent to know that we need them in medicine. And that's our primary reason why we came about and doing this webinar. And Patrick, I know you understand that it goes further back than the webinar when we were riding up and down the road of Pennsylvania, New York, and New Jersey doing churches every
Saturday.
every month.
Yeah,
Yes.
yeah.
Giving up a Saturday to go answer medical questions at churches. Go ahead.
I just want to say that there were 2 questions left in the chat and I answered them in writing. So those people can just look in the chat and get the answer. Thank you.
Thank you, Natalie. Thank you very much. So, the thing of it is that it's all about caring and sharing. So our communities, that's how we do it. Please let others know that we exist and that every second Saturday we're here to answer their medical questions. The most important thing that I'm going to say today in closing is that do not change any aspect of your medical care until you consult your physician, please. Only your doctor. And we're all different. Each and every one of us have differences. Only your doctor can truly take care of you from a medical standpoint. And until next time, listen, I'm so looking forward to next month. So until next time, I want to say peace to each and every one of you. And again, all the brothers and sisters here, thank you very much. We're looking forward to next month. Peace, everyone.
Thank you.